I love when I hear about doctors who go outside the box to help their patients. And this week's guest is no different. Dr. Kristin Baier uses diet and lifestyle to reverse obesity and even type 2 diabetes in her patients, often getting them off their meds within 6 weeks. So check out this week's episode to hear exactly what she's doing. Thank you for joining me today on another episode of Hunger Hunt Feast. With me is Dr. Kristin Baier. Kristin, welcome.
Thank you. Thanks for having me on.
Oh, I appreciate you coming on. Kristin, tell us a little bit about yourself or where you're practicing and what you guys focus on.
Yeah, so I am a double board certified family physician and obesity medicine specialist, and I just relocated from Chicago to San Diego this past summer and opened a private practice with my partner, Brian Lenskis, and we do direct primary care and metabolic health, which is basically medical weight loss and a service provided for patients whose own primary care doctor might not be familiar with the low carb or ketogenic lifestyle and the labs, and who just want a little extra guidance in that arena.
Awesome. So to be clear, a non-medical or non-surgical weight loss, it's focused on lifestyle is what it sounds like. And
Yep, exactly. We take a lot of time to educate our patients on lifestyle, nutrition, and everything else to help improve longevity and optimize the quality of life for our patients.
Gotcha. And that's, I believe, Low Carb MD in San Diego, correct?
Yep, that's
Okay.
correct.
I remember we connected. I think you were studying for your boards for the obesity medicine, I think, at the time, and you were still in Chicago, obviously. So you've had quite a transition over the last year or so. As if the whole world hadn't, you threw in a few other twists for yourself, didn't you?
Right. Yeah. Studying for a board exam and then moving across the country during a pandemic was interesting, but it all works out somehow.
I bet. Well, great. Sounds like you're in a great place. I love Cindy. I lived there for a short time before coming to Nashville, and it's a beautiful place. It's one of my favorite
Yeah.
cities for sure. So what? Now, obviously, you're a family board certified family medicine physician prior to the obesity clinic. What led you in that direction? What was it that took you towards treating weight loss? Essentially, medical weight
Right.
loss.
Yeah, that's a good question. So, in primary care, when you're working for a major healthcare system, you really don't have time to educate patients on nutrition and lifestyle, nor are we really given the education for it in medical school. It's, kind of what happens with vitamin deficiencies and protein deficiencies, and then you refer your patients to the dietitian for diabetic education and weight loss education. But my experience was that was horribly ineffective. Patients were getting more and more obese and more diabetic, and medication needs were increasing. It seemed like every year. And I thought, this is just crazy. So I really wanted to figure out how we could be more effective clinicians. And a lot of it was inspired by my own personal journey through diet and lifestyle to modify chronic disease. I was diagnosed with lupus when I was in medical school in my early mid 20s. And when you're diagnosed with something like that, a million thoughts go through your mind. And my first thought was, I do not want to be on prednisone my entire
Right.
life. One of the most notorious side effects of prednisone is weight gain. And to anyone, but especially someone, a female in their 20s, that's the last thing you want to hear. So I
Right.
started doing my own alternative research to come up with other solutions to see if I could mitigate the disease in any way. And the first book I picked up was on a vegan diet. And it was a story. This lady had no credentials of any sort. She just said being vegan helped with her lupus symptoms. And I thought, perfect. I'm going to become a vegan. And overnight I eliminated all animal products and I stayed vegan for about 5 years. And throughout that time, I developed horrible migraines, a vitamin B12 deficiency. I went on antidepressants. I was incredibly irritable, and It was clearly, yeah, it was clearly not working well for me. So then I discovered the work of Rob Wolf
Oh yeah.
through the paleo solution and his paleo autoimmune protocols. So I transitioned from vegan to paleo and had improvement pretty quickly with my lupus symptoms. My energy improved. I was able to get off of the antidepressants, but I still was not quite 100%. And I was still battling migraines almost every day, and they were debilitating. I'd be throwing up. Sometimes would have symptoms of a stroke and paralysis. So,
Oh my gosh. So really, they hadn't subsided at all during the vegan time.
no, I didn't even have migraines until I became vegan. And I'm not going to say veganism caused migraines. It could have
Right.
been an underlying factor, but yeah, no, the migraines just kind of came out of nowhere in my upper 20s. And my
Mm.
lupus symptoms, like they were absolutely improved on paleo, but I would
Okay.
still require a burst of prednisone plus my daily preventive medications.
Gotcha.
But at this point, I wasn't even too concerned with lupus. It was the migraines that were having the biggest detrimental impact on my life. And I came across a book called My Migraine Miracle by Dr. Josh Turknett, who is an expert in the field of neurology and migraines. And reading his book, that was the first time I had ever really heard of a ketogenic diet. And in addition to implementing a high fat, low carb diet. He had some other things like the importance of stress management and sleep and eliminating processed food and artificial sweeteners and all of that. But did some research on my own and realized, okay, there's some good research here. There's studies that show it's safe and effective. And that kind of led me down the rabbit hole of where our guidelines came from around cholesterol and saturated fat. And after a couple months, I felt comfortable enough implementing a ketogenic diet. So I did. And within 2 weeks or so, my migraines were completely gone.
Mm.
And just for reference, I was on 4 daily medications to try to prevent migraines,
Wow.
plus Botox injections all around the base of my neck and my skull every 3 months, plus the medications I took when I actually had them. So within,
Wow.
yeah, I know I was like a walking pharmacy. And it was I thought it was too good to be true. For the first few weeks without a migraine, I thought this is beginner's luck. Something's going to happen. They're going to come back. And they didn't. I eventually pretty quickly weaned off of all the migraine medications, and it was fantastic. But then I realized a lot of my lupus symptoms were actually getting better too. The muscle aches, the joint pains, the malar rash on the face. And I thought, this is crazy. I haven't been on prednisone for a while. And then I kind of started digging around a little bit more on keto for autoimmune disease. And while there isn't solid, research out yet, there's a lot of anecdotal evidence. And then trials are currently underway. And it was just, I'm a full believer. And I think it's a lot. Has to do with the anti-inflammatory effects of ketones themselves. But to circle back to your question, kind of my own experience with how dietary changes really changed my life and put chronic diseases into remission. I thought it's crazy that we're not teaching patients this, and we're not given a
Right.
structure to even make that a possibility when you're seeing a patient every 15 minutes once a year.
Yeah, that's not a lot of time to really change someone's life, is it?
No, not at all.
Or reverse a debilitating disease like whether it's diabetes or an autoimmune. Well, and then I think it's, to be honest, the information given on nutrition in whether for doctors or nurses is completely flawed and the opposite of what I mean. My wife's in nursing school at the moment. She's kind of got started and she's in a
Oh,
basic
great.
biology class. It's online, and overheard the instructor say, you can get a lot of your vitamins and minerals from cereal. There's a lot of that's a great resource for vitamins and minerals, breakfast cereal.
Oh,
And I'm
no.
like, really? We really haven't moved past
Oh,
this. So
yeah.
let's strip everything out of a really, really inadequate food anyway. Let's strip everything out, reform it into something, throw in some sugar, fortify it with lab created vitamins and minerals, which you probably won't digest or assimilate anyway, and call that a recommended source from the medical community to hospitals, sending these women, these people, nurses, my wife, but no, to out to the world, out into hospitals, take care of people, telling them cereal is a good source for their vitamins and minerals.
I know. It's
I,
outrageous.
I'm just, it is, but yet it's a good reflection of why we are where we are, right? I mean,
Absolutely.
you're in a business where you're dealing with medical weight loss, and I assume there's some diabetes going along with that, type 2 diabetes, autoimmune,
Oh,
but
yeah.
just type 2 diabetes alone. Type 2 diabetes is what, 320, 30 billion a year costs.
An
And
astronomical number. Yeah, for
yeah,
sure.
and it's increasing like every 5 years, it goes up like 25% or something like that.
Mhm.
So, and it's lifestyle driven. I mean, you're obviously treating it with lifestyle. So it's
Yeah,
lifestyle driven.
100%. 100%. Now, not type 1 diabetes,
Obviously. Yeah.
not LADA, which is latent autoimmune diabetes of adults, which is commonly incorrectly diagnosed as type 2 diabetes. But yeah, true type 2 diabetes, completely controlled with lifestyle.
Amazing. And of course, you're in obesity, which we can obviously tie obesity to lifestyle very, very easily.
Mhm.
So how, I mean, so what you're teaching people now is completely the opposite of what you learned in, let's say, med school. Was it any different when you got your obesity, went to your obesity boards and your all the
Yeah,
obviously
all
there's some
the
education
training.
associated with that.
Mhm.
What was that based on? Obviously it
Right.
wasn't based on keto, but what was it?
Yeah. So I would say the overall take home message was obesity is complex. We really don't know how to treat it. We have some options that might work for some people, that might not work for some people. Keeping weight off is going to be hard, but no, I mean, I don't want to knock the seminars I went to, and including Harvard, the Blackburn course at Harvard, but it was very, very clear that we still don't have a good handle other than we're going to push some medications. And there are a lot of medications that are coming out for obesity management. And I'm not arguing that they work. I mean, some of them are very effective, but they need to be used in conjunction with lifestyle to
Right.
really change the habits. And so much of it, I would say like 75% of weight loss is changing this neurological pathways and the psychology around it and changing habits and the self-talk. And there was hardly any mention of that in our training. It really is education on what pharmaceuticals to use and comorbidities and genetic causes, which a genetic cause of obesity is very, very rare. People like to say, "Oh, I have a thyroid problem," and "Oh, my whole family's obese. It's in my genes." But when we break it down, that's you might have a predisposition, but
Right.
um,
Some epigenetics.
yeah,
You're turning
that
something on, but at the same time you can turn it off with lifestyle as well.
exactly,
Yeah.
exactly. So Um, yeah, it's the obesity medicine board certification is definitely not empowering for patients. Whereas I feel like what we're doing, we're going to give them the tools and techniques, educate them. And sometimes if they want a medication in conjunction with that,
Mhm.
fine. I'll tell you in my practice, first visit, I ask every patient what their expectations are if they want a medication, just to kind of get an idea of where their head is at. And all of my patients say, no, I want lifestyle. And that might just be that those are the type of patients our practice attracts.
Right.
But there is such a demand for it. And I think people with social media and the internet, they're able to educate themselves and see, something's not adding up when we're eating breakfast cereal for, for our vitamins and minerals and eating 6 times a day. And
Right.
we're gaining weight and our blood glucose is going through the roof. People are realizing there's something wrong and are seeking out uh, practitioners of all types to help them get their health under control.
Right. Right. And the insulin isn't helping with that either, is it? If you're on short-term insulin, short
Oh,
acting,
yeah.
and then long acting. I mean, it's just constantly elevating the insulin. How are you going to reverse the process?
Exactly. Exactly. And once a diabetic patient is on insulin, It is hard. I mean, they need some serious lifestyle interventions there because insulin is a fat storage hormone,
Mhm.
and we're just making them more and more insulin resistant by increasing their insulin
Right.
needs. But it's just a cycle that just continues, and the best time to intervene is before we get to that stage.
Sure. Sure. Now, do you have some people coming in who are wanting help with diabetes, but they aren't quite obese? Because we do have a certain population that is what they call TOFI, so thin outside,
Yep.
fat inside. So you got the visceral fat, the fats around the organs, and
Yeah.
the viscera, and and affecting their insulin resistance. But they aren't quite their body type isn't one. They don't have a phenotype that gets heavy necessarily. They just get metabolic disease without the obesity. So is that a part of your
Yeah.
practice as well?
Yeah, we do see that, and that is much more common. There's like ethnical differences too.
Right.
Um, Caucasians are able to get very, very obese,
Right.
and they are typically, not all of them, but it takes them longer to get to that point of metabolic dysfunction where they do develop diabetes. Um, for example, Asians have a much lower threshold, and they are
Right.
more likely to be the TOFI type, where they look like they're a normal weight, but they've already hit their maximum fat storage capacity, and you're having just all types of metabolic dysfunction, and they get diabetes at a normal weight, what we would consider or I wouldn't say normal weight, a lower weight than
Right.
what we see here.
What we consider a healthy weight would be,
Exactly.
quote in quotes, healthy weight. Yeah,
Yes.
I've understood it's like Indian, so Eastern, so Indian and Asian populations tend to be more that
Mhm.
way. Although, could you just explain like a maximum fat, which you said, just for people listening, like you said, they've hit their maximum weight gain or
Personal fat
personal
threshold.
fat threshold. That's a great way to say it. Personal,
Yeah,
perfect.
yeah. So no, that's a good question. And just to be clear, we still like there's so many theories about what causes
Right.
obesity and metabolic dysfunction. And now we're really taking a strong look at the polyunsaturated fatty acids. But the personal fat threshold is basically where we are looking at our fat cells, right? We call it adipocytes.
Mhm.
And they can either grow in size or they can reproduce. And once they stop being able to grow in size, hypertrophy, they start reproducing. And that's when we get into trouble. Fat cells are not just sitting there dormantly. They are very active. They are part of the endocrine system. They're sending all types of chemical messengers and inflammatory signals, which can create chronic inflammation, but it
Mhm.
can also cause insulin resistance, which is the start before you even get to prediabetes or diabetes. And kind of one of my pet peeves is when physicians of primary care only check hemoglobin A1C or glucose levels, because that's telling
Mm.
us, okay, what their glucose is. It doesn't tell you anything about how much insulin it's taking to maintain those glucose levels. And we know that the window between when your insulin starts rising and when you have an abnormal glucose or elevated glucose level, it's about 10 to 15 years. That is a decade of time we have to intervene to stop the progression of prediabetes to diabetes that we're completely missing. When you
Right.
just check the glucose level, you're not looking at insulin, you're not able to figure out the insulin resistance, and I just think it's a huge oversight on part of the medical community.
Absolutely. Absolutely. So those insulin levels are rising in order to control the blood sugar, but if you're not testing for it, then you're masking a problem that is developing and no one's paying attention to it. No one can see it on the blood test because you're not looking at
Right.
the first action, which is the elevated insulin. You're waiting for it to develop into insulin resistance where we have elevated blood sugar before you even begin to address it, at which point you might need medication, right?
Exactly, exactly. And when the insulin starts rising, that's when people start developing hypertension, and they might have
Mm.
some dyslipidemia. Their cholesterol numbers are a little off
Or
their baseline.
triglycerides.
Exactly. And
Yeah.
it's like we just say, "Oh, it's part of aging. That's why your blood pressure is going up. Oh, that's why your cholesterol is going up." It's like, no, there is a reason. There is a physiological reason. We have to get to that point.
Right. And what seems to be happening younger and younger, we see people in their 50s on blood pressure meds like it's normal, and then
Yeah.
their blood sugars, and there's really no reason for it to. I mean, at this day and age, when we have a life expectancy that should be continuing to go up, so it's late 70s, let's say. Why would your blood pressure start going up at 50 unless there's a problem?
Right.
Unless you have something disease beginning
Yeah.
to take hold. Yeah.
And it's true. And it's, I'd say even like upper 20s and 30s now, it's become like not unheard of for people to be on blood pressure medications. And there are other causes of hypertension. There's primary hyperaldosteronism, renal artery stenosis. There are other causes, but
Right.
for the majority of patients that we're seeing and treating in clinics, it's most likely due to metabolic dysfunction, elevated insulin levels that act on the kidneys, are causing water and sodium retention. Um,
Uric
and it's,
acid built up
yeah,
from the
yeah,
sugar and causing,
exactly.
the nitric oxide kind of reduced, and they just can't adjust. So the blood vessels just can't adjust to
Hmm.
the stresses that they need to deal with. That's wow. Now you mentioned polyunsaturated fats as a possible trigger cause of some of these diseases. Do you mind unpacking that a little bit? I know it's all theory. I know this is all like
Yeah.
very progressive and ahead of the curve, but did you mind opening that up a little bit?
Not at all. It's actually like one of my favorite areas to kind of research and
Me
play
too.
around with right now, because we do. So for a while, and like with Dr. Jason Fung's obesity code, he really brought to the limelight that insulin model of obesity, which was if your insulin level is high, you won't be able to lose weight or keep weight off. You're insulin resistant. And it's because insulin is a fat storage hormone.
Mhm.
It kind of puts a lock on your fat cells and prevents them from releasing fatty acids to be taken to the liver to produce ketones. But what we have since seen and noticed, there are plenty of people that have normal or low insulin levels that are still struggling with their weight. And it's a lot more complex and everything. But
Right.
um, the question comes to be, one, what's causing or triggering the obesity then if their insulin levels are low, and two, where does insulin resistance play into all of this and its role in obesity and everything? And what we know for sure is that once someone has metabolic dysfunction, right, they've developed elevated glucose readings, they have high insulin levels, they probably have high triglycerides, they probably have blood pressure issues. When they are at that level, we know that carbohydrate restriction absolutely helps and absolutely helps improve a bunch of markers. Their insulin comes down, their glucose comes down, their triglycerides come down, usually HDL goes up. And the debate becomes, well, what caused that metabolic dysfunction and that systemic insulin resistance in the first place? And it all comes back down to like functioning of the mitochondria, and which is the powerhouse, the energy generator of the cells. And did carbohydrates cause this to happen in the first place, or was it something else? And what we're seeing is some people tolerate carbohydrates just fine. They don't have a problem. And they can eat a high amount of carbohydrates and remain insulin sensitive and have metabolic health. And then there are others who just do not have that luxury. So what is kind of the commonality, and why did all of this start, all the obesity and diabetes and hypertension and cancers and autoimmune disease? What happened that made all of this skyrocket when we've been eating carbs for centuries, or
Right.
since the beginning of time, basically, especially towards the people near the equator? But what has really kind of triggered a new way of thinking is the introduction of polyunsaturated fatty acids, which are your industrialized processed seed oils, your canola oil, your safflower oil,
Right.
sunflower oil, peanut oil, all of these things that are generated in a lab,
Right.
in a plant, some kind of manufacturing. They're deodorized, and it's not a natural food. And the thought is this is causing a lot of dysfunction at the level of the mitochondria, and it's creating a lot more toxicity in the cell. It's
Mm.
impairing the cell's function, and maybe that is actually the cause of why insulin resistance and metabolic dysfunction develops. And then once it develops, we know we have to back off of the carbs because we're not able to process them. Again, it is a theory, but there is a lot of emerging evidence, and the timeline kind of fits.
Mm.
as far as when all of these chronic modern diseases started skyrocketing and when we introduced these type
Right.
of PUFAs.
Things like Crisco and
Yes.
margarines and stuff like that, right?
Yeah.
Around the early 20th century, give or take.
And kind of to add on to that, so for so long, and like the breakfast cereal, we've been told eat these vegetable oils. They're good. They'll
Right.
lower your LDL cholesterol, which is, quote, your bad cholesterol. And that is true. They will lower your LDL
Yeah.
cholesterol. But we also know that the LDL model or theory of heart disease is greatly flawed as well. And
Yes.
we don't even test, or a lot of practitioners don't even break down the LDL by pattern type or if there's LPA or apolipoprotein B present. I'm more concerned about the triglyceride to HDL ratio. So if the
Sure.
vegetable oils are lowering your LDL, but you're getting insulin resistance and diabetes, and it's increasing your risk for cardiovascular disease,
Right.
who cares about the effect on the
Right.
LDL?
Right. Yeah. Being dead with corrected LDL is not a desirable outcome. Right.
Right,
Right.
exactly.
Yeah. Yeah. So even whether you're taking a statin or you're eating more plant oils instead of animal fats, lowering your LDL is not necessarily, is certainly not making a difference, because we have plenty of people having heart disease and diabetes with
Mhm.
lowered LDL or normal levels of LDL.
Yeah,
And there's a
it's
lot of benefits to LDL as far as immune function and
exactly.
brain function, and we generate most of it within our bodies. So, there's a lot of things that if we lower it, we won't be missing out on as far as delivering vitamins and nutrients and stuff like that.
Yes. And I
So,
do think it's a bell-shaped curve, like most things. Our body
mm,
wants a level for homeostasis. We absolutely need LDL cholesterol. It's vital. And people with low LDL have a higher morbidity rate and mortality rate. So,
right,
there's caveats with that too, with chronic disease and impaired cholesterol synthesis. But it's also important to note that up to 50% of patients who have a heart attack have normal LDL levels. It's
right.
over 90% who have a heart attack have insulin resistance. So,
Much stronger correlation there.
yeah, yeah, you can take away from that what you want, but
Yeah,
I'm much more worried about insulin resistance and
sure.
triglycerides and
Triglycerides. Yeah, those
yeah.
two kind of go hand in hand, right? The
Mhm.
high triglycerides and insulin resistance, and
Yep,
basically your lipid in the high amount of fat in the blood, which
correct. Yeah,
essentially, okay,
yeah,
which could be causing inflammation and sort of other things. But basically on your, if you're looking at a lab test, that's what you're looking for as
yeah,
a red light, as opposed to total cholesterol levels or total LDL. You're
yes,
looking
yes,
more at HDL to triglyceride ratios, or um, blood glucose, insulin peptide test on that scale. And so, okay,
yep.
awesome, fantastic, that's great. So, what is let's get into some of your treatment, if you don't mind. Like, where do you start? I mean, you're just basically recommending a ketogenic diet, but that can take many forms. If you go on the internet and look for a
Yeah,
keto diet,
yeah,
you're going to find a few different manifestations of that. So, how
yeah.
are you guys coaching your clients?
Right, and I will say it, like, I don't the ketogenic diet is a tool, and if I have someone who is having a lot of inflammation, if they have autoimmune disease, if they have IBS or Crohn's or ulcerative colitis, I do think an elimination diet and a ketogenic diet can be very helpful. But I do have a lot of patients who are not on a ketogenic diet. And I have some who are very clear they don't want to be, and that's
Mm,
fine. The first thing I do for every patient is I try to get them off of processed food.
mm,
If you're going to do one thing to improve your health, I would say it doesn't matter if you're vegan, if you're carnivore or carnivore-ish or keto, whatever, get rid of the processed food. They are
absolutely.
going to like hijack your hunger and satiety hormones. You
Mm,
have a bunch of hormones in your digestive tract, like GIP, GLP-1, peptide YY, that are supposed to be triggered when you eat and send a message to the hypothalamus in the brain that, hey, we have nutrition on board. We don't need to eat anymore. A lot of the processed foods just bypass those chemical messengers and hormones and transmitters. So you don't get the message that you're full. very easy to overeat. It causes a lot of glycemic variability, which is the ups and downs in your
Mm,
glucose level, which we don't like. We know that it can be rough on the vascular endothelium and can
oh
be
yeah.
implicated in disease processes as well. So my first approach, I don't care what type of diet you want to do, it's let's get rid of the processed food. And then once we have that, then I talk about meal timing, which I think is
Mm,
also very important. I'm personally a fan of time restricted feeding and intermittent
awesome.
fasting. Yeah, huge benefits there too. And do I do that with every patient? No, some are very clear they don't want to
Right.
they don't want to fast, which is fine. But I get rid of snacking. Then you
Mm,
have 3 meals a day, and the reason for that is to also control insulin response, right? So you
right.
can control your insulin secretion by decreasing the carbohydrate content in food or by decreasing the frequency with which you're eating. So, multiple benefits there too. And like our ancestors, they weren't sitting around snacking all day, and it's just, yeah.
They were
So
hunting or
yeah,
gathering. They had to
exactly,
work for it. They had to go
exactly.
work for that food, didn't
Yeah.
they?
Yeah, they weren't sitting at their computers 2 feet from their kitchen all day long.
Right.
So yeah, basically, I mean, those are my foundations. If
Okay.
we can just get people off of processed food and snacking, I would say I've had patients lose over 10 pounds in a week just by
Oh,
doing
sure.
that. Granted, these are people that have,
A
a
lot to lose.
significant amount
Yeah.
of weight to lose, not someone looking to lose the last 5 or 10 pounds, but simple things like that. And once
Yeah.
we can control hunger,
Right.
sticking with a way of eating is much easier.
So would you say that is more of an impact on the hormonal environment in the body? It's not really or a calorie restriction. So
Ah,
in its initial, I mean, when you see a 10-pound loss in a week, there's or and say consistent weight loss thereafter, necessarily 10 pounds, but consistent weight loss. I mean, what comes first?
that is such a good question. And it's completely you could get very different answers depending on who
Oh yeah.
you ask. So I I think one of the downfalls of keto and low carb is people think they can eat whatever they want and however whatever quantity they want and still
Mm,
have weight loss. And that is not true. I've seen many people gain weight on on a ketogenic diet because they're eating fat bombs and putting
right.
butter on everything.
Right.
So I caloric restriction is needed to lose weight. And how we go about that varies drastically. If you're eating, I don't know, Pringles and Oreos, you're not going to feel satiated. You're still going to be hungry, but you're going to be at your calorie allotment pretty quickly. It's
Mhm.
not satisfying food. And a lot of low fat diets are very similar. You can eat fruit and vegetables and things, but you're not getting dense nutrition that's in a bioavailable form.
Right.
And you're not eating the foods that are going to trigger those satiety mechanisms like your proteins and fat. So, if we get rid of the processed food and say you're eating eggs and steak and seafood and maybe some vegetables and fruit too, you're going to stimulate your satiety hormones and
Mm.
you are going to feel more satiated. And that is going to make it easier to reduce your caloric consumption. Like you can eat, 800 calories of steak and feel pretty full. It's very easy to eat 800 calories of Oreos and still want to eat more.
Oh yeah. Well, I mean, even think about what makes up your average fast food meal that someone might grab on a random busy night, right? A busy night, or a busy, and they go grab, whether they grab a pizza or they're getting, something from like a burgers and fries and that kind of thing. What is making up most of that food that they're getting is a processed food. It's not very nutrient dense as far as it's calorically dense, but it doesn't have the nutrients or the nutrition that you're talking about, where you're going to trigger the satiety hormones and the fat soluble vitamins and minerals that we need from whole food, right?
Yeah.
So um, it
The
sounds like you're saying you balance the hormones and then the caloric restriction sort of follows.
Yes, yes. And it
Okay,
can take a couple weeks to really kind of repair the hunger and satiety
sure.
cues. And then bringing it back to the psychological component, a lot of people eat out of habit. Oh, it's lunchtime. Oh, it's 3 p.m. I usually have a
Right.
snack. Breaking those habits, determining what is true hunger, what's a
Mhm.
desire for food, and what's a craving is a big part of the process too. And it takes a while for patients to really trust their hunger cues again, to know that it's not just a craving or a desire or boredom. The other thing with processed food, it is near impossible to find a processed food or fast food that doesn't have a processed seed oil in it, the polyunsaturated fatty acids that we talked about. So it's just an inflammatory
Right.
bomb waiting to go off there every time you eat those McDonald's French fries or that
Right.
that pizza and even like these granola bars and things and
Right.
protein bars that are touted as healthy foods. Take a look at that ingredient list. They are swimming with these PUFAs that I personally think
Yeah.
we should be avoiding.
Yeah. As well as the grains I mean, so you got soybean oil, which is one of these
Oh,
oils you're talking about, but then you might
yeah.
have soybean isolate protein put in there and makes it look good. Or you have a soybean, any kind of soy filler in there of a 20 different names, plus the wheat flour, the corn, all these processed foods. So you got
Yeah.
corn oil, and we've got a corn meal, and we've got a corn
Yes.
byproduct in there, high fructose corn syrup probably added in. But I see what you're saying. So the processed food is made up of those elements that are irritating our cells, that
Yeah.
are causing inflammation.
Yes. Yeah,
Okay.
that cause inflammation, mitochondrial dysfunction, and are hyperpalatable, very easy to overeat. They're going to hijack your hunger and satiety hormones.
Mm,
It's a cascade of problems that follows. So
wow.
yeah, that's why I'm a firm believer in getting rid of processed food. And I'm not going to say it sounds easy. It's not. It's hard for a
No.
lot of people, and sometimes it's a transition, right? So
Right.
sometimes someone who has a sugar addiction, we go to sugar substitutes, and then there's different tricks, and everyone kind of comes in at a different stage. And but the goal is to get them off of all type of sweeteners, including artificial sweeteners and off of grains, off of
Okay.
processed food.
Okay. I'm sure alcohol plays a role in there somewhere as well.
Yeah, yeah, that's I would say most of my patients actually don't. Oh, I shouldn't say that. There are a few that are unhappy. I just do what you want, but alcohol is not going to help you get to your goal. Like
Right.
that's all I'm going to say. Some people are more upset when I suggest eliminating dairy, which I don't have a problem with for a lot of people, but autoimmune disease and food
Right.
sensitivities, yeah, I get rid of dairy pretty quickly too, and
Okay.
that creates more pushback than anything.
Gotcha. So it sounds like you've got you're not just treating obesity and not even limited to diabetes, but you've got autoimmune coming in. So you're kind of, rather than like allopathic medicine, typical medicine being in silos of, you've got one doctor over here treating this symptom, another doctor over here treating this symptom, and those guys don't talk. And then another guy over here,
Yeah.
you're really, you're almost, I'm going to say almost, I say almost, it's not the right word, but you are holistic. I mean, you are looking at what's the problem, and you're looking for the root cause at this point.
Yes. It is against my training, how I was trained,
I was
but
going to
that
say
is
it like that, but
exactly no,
that's
I will. I'm very open about it,
okay.
right? But that is exactly it. I do have, it's funny, I have patients that come to me for weight loss, and I see they have a history of migraines or they have rheumatoid arthritis, and I'm like, oh, double win for me, because we're going to try to get to the bottom of all these issues. And some patients, honestly, they don't want to do it. Like for
Mhm.
a lot of the autoimmune disease and things, I do start with an elimination diet, which is another word for carnivore for the most
Right.
part.
It's an
And then,
excellent elimination diet. It's probably the best elimination diet
yeah,
you can find. I mean, just
absolutely.
anything inflammatory. I tried it myself just for that reason, and it was like it is. I mean, you can just feel one swelling, water dropping out of your body. I mean, it's like, and then it's just everything kind of calmed down,
Yeah.
and it's
Yeah.
not what you would assume if once you've been kind of indoctrinated with all the nutrition advice we've had over the last 50 or so years. You wouldn't think that a carnivore diet would be anti-inflammatory or an elimination diet. It's not what you think of. You're thinking of fruits and vegetables as an elimination diet.
Yeah.
right? Typically, most people,
Yeah.
that's where they're going to go, or they're going to have juices. They're going to do a
Yes.
juice fast for the elimination diet. And I'm not knocking juice fast in and of themselves, but I'm saying as an elimination diet, what are you trying to eliminate? So maybe let's, if you don't mind, what does that carnivore diet eliminate that wouldn't be eliminated by eating what we call whole clean food? So like vegetables, which could be part of a normal diet, but they're
Mhm.
not part of an elimination diet. Do you mind
Yeah.
unpacking that a bit?
No, not at all. And just wanted to also add, like with the carnivore diet, I don't do a carnivore diet with patients expecting it to be lifelong. It is a temporary thing, and we try to slowly reintroduce foods. But with plant foods and grains, it's a lot of the anti-nutrients that are in them. They're lectins, the phytic acid, the saponins, oxalates, things that people can become sensitive to and can also trigger leaky gut, which is a term we use for when the junctions, the endothelial junctions in the lining of your intestines are looser than they should be, and food particles and things can quote like leak out,
Mm-hmm.
and it triggers your immune system through molecular mimicry too, which can then precipitate autoimmune flares in people. The other thing is just not true allergies, but food sensitivities. Like,
Mm.
we all have varying levels of enzymes. We all have a different gut microbiome that plays a big role in digestion as well. So what we're really doing is getting rid of everything that could trigger the immune system or create leaky gut or create inflammation within the intestines, and make digestion a little more challenging or painful, and people have bloating and vomiting and nausea and loose
Right.
stools, what have you. So I wish I could take credit for this, but Paul Saladino actually had a good analogy. It's like
Mm.
when you eat meat, it's like putting the right parts of your body. If you're eating plants, it's like taking parts of a MacBook Air and trying to put it in your, desktop Dell
Gotcha.
computer. It's like two different operating systems. You need to keep the operating systems the same to have the desired outcome. And biologically, we're much more similar to animals than we
Right.
are to plants, right? So in
Absolutely.
theory, it's like putting the correct operating system into our body.
Right. The same types of fats, the same types of proteins, the same, right. Those,
Exactly.
yeah. So we're made up of mostly stearic acid, right? Fats,
Hmm.
and
Yeah.
which is an animal fat. You're going to find a lot of stearic acid in a plant.
Yeah. And it's a
Uh,
saturated fat.
and
Yeah.
it's a saturated fat. That's just what our brain is primarily made of and uses for connections and building tissue. So it's like for like, so to speak. I would imagine. Yeah.
Yeah. Yeah. Exactly. That was much more gracefully said than
No,
what
you
I was
you
trying to
explained it
explain.
very
Yeah.
well because it makes sense. I think they're opposite. I haven't heard him say that, give that analogy with the computer, but that makes perfect sense. It's a different operating system completely,
Yeah.
and different needs by that animal as opposed to a plant. Plants have cell walls. We have cell membranes that are made of cholesterol primarily, that are
Yeah.
fluid, whereas cell walls and have their plant fat is for more rigid cell walls. So that could cause a problem if we're trying to replace our fat, cholesterol, and our fluid cell membranes with what came from a cell wall that was more rigid. We might have some issues. We might have some inflammation.
Exactly.
So
Yes.
I get it. So that's your elimination, and then it's something. So after elimination period, you can kind of work in foods based on the person's general taste, a mix of tastes and lifestyle that
Yeah.
you're going for. Okay.
Yeah, usually I'll ask the patients like what they miss the most, what they want to try adding back in first. And it's usually we do it very slow, one food at a time. Maybe it's avocado, see how they do for a week. If symptoms
Mm,
come back, if they're okay, then maybe we try adding in a few vegetables that they like, or whatever the situation. But I'll
gotcha.
tell you, it's dairy, grains, artificial sweeteners, and the nightshade vegetables are usually the problems. And
Gotcha. You're talking about
yeah,
for autoimmune or just all sorts of digestive issues as well?
autoimmune especially, but other digestive issues. Yeah, and I don't put a ton of faith in food sensitivity tests, but sometimes people will get them done, and it
Mhm.
correlates. which they're not always happy about. Coffee is also a big trigger, chocolate.
Yeah. Some things you're willing to fight for though, right?
Yeah, exactly. Exactly.
Some things are like, coffee. Okay. Short term. I'll give it short term, not long term. That'd be
Yes.
the first thing I would want to reintroduce would be coffee. If there's
Yeah.
one thing I'm like, please beg you, coffee,
Yeah.
introduce. Let me make
I
sure I tolerate that.
Right. I think it's funny in the carnivore community, people will refer to themselves as carnivore plus coffee, right?
Right.
It's like the
Right.
one thing people don't want to give up, and most people are fine with that, you
Oh
know.
yeah. Oh yeah. It's usually, I mean, there's some benefits. So there's some longevity benefits, I think, found to that. But yeah, it's definitely especially if you're trying to burn fat all the time, it's like doesn't hurt.
Yeah, very true. Very true.
Awesome. So what do you so as in terms of diabetes, I mean, most people don't realize there is a successful way. I mean, we're told diabetes, obviously type 1 diabetes is a for life disease for the most part. Type 2, we're still told is chronic and progressive by the mainstream medical community. Are you seeing people not either controlling or getting off of meds or reversing type 2
Oh,
diabetes?
absolutely. We can get patients off of their medications very quickly, usually within a couple weeks. And that might be oral
Awesome.
agents, that might be insulin. But yeah, we give our patients continuous glucose monitors so we can closely track, because when they um, go from the standard American diet to eliminating processed food to low carb, their insulin and diabetic medications are weaned pretty fast. We want to make sure they don't drop to hypoglycemic levels. There's also a few medications out there that, if you start a low carb diet or a ketogenic diet, can actually increase your risk of ketoacidosis, and that's the SGL2 inhibitors. So,
Mm,
we have to be very careful about what medications our patients are on, and maybe we take them off of that medication first before implementing diet changes. So, just my word of caution for diabetics out there, we can absolutely reverse your type 2 diabetes and get you off of your medications, but you should absolutely do it under the supervision of someone who knows what they're doing, a doctor preferably.
absolutely. Yes. Yeah. You don't want to try that on your own if you're already on meds. That would be you definitely need somebody looking over your shoulder to help you manage that.
Right, right.
Wow, amazing though. I mean, what a way to change someone's life though, is to reverse
Yeah.
diabetes. That's like, I mean, one, financially, very expensive for most people. They're usually spending $8,000-$10,000 a year on insulin, and
Yeah.
then as far as all the other medical problems that cascade from that, heart disease, you're pretty much guaranteed, possibly dementia. You're just at
Yeah.
greater risk for so many other metabolic diseases once that takes hold. So being able to reverse that, I mean, you're truly, you're saving their life, you're improving their health span. I mean, they're just going to live a better life, and you're doing it through lifestyle, not medication. So
Exactly.
you've empowered them to take hold of their health, essentially.
Yes, showing them that it is not going to be progressive if you can change your lifestyle and you can control this. And unfortunately, it's not a temporary fix. These have to be lifelong changes. When you
Right.
resort back to your previous habits, your diabetes will come back. But for most people, it's not an issue. They feel so good once they get off of their insulin and have
Right.
normal glucose levels without the variability and all, like you mentioned, the comorbidities that come with it. They it like they're sold. They don't need they don't need to be
Right.
reminded. It's a permanent change.
Right. Absolutely. Now, I know people in the low carb community. There are some people who say, "Oh, I hear I don't want to call it an excuse, but a complaint or concern about lowering thyroid levels, or affecting their thyroid." One which you could say, is that a real concern compared to what you're fixing, and is that really
Mhm.
something that should be, or that always needs to be treated,
Right.
or how would you treat it if you came
Great
across it?
question. So the most common cause of hypothyroidism, which is low thyroid, is Hashimoto's,
Mm,
and autoimmune sources of low thyroid. So I've actually seen thyroid function improve with ketogenic diets and elimination diets. And on the flip side, there's the camp that argues your thyroid hormones absolutely are dependent on carbohydrates and
Mm,
they're needed. And for the record, your body can produce glucose. It does not need carbohydrates for a
absolutely.
source of glucose, which I know you know, but just
No, it's good that you
people
say it,
are
but
like,
you absolutely,
yeah,
your liver creates all the glucose you need.
yeah,
So yeah,
exactly. So you can eat zero carbs and your glucose levels will be just fine.
yeah.
Um, But with what we're seeing with long-term ketogenic diets and low carb diets is sometimes their levels of like free T3, which is the active thyroid hormone, will decrease. But their TSH, which is a thyroid stimulating hormone, is normal. And these hormones go in a feedback cycle, right? If your T3 is low, it's supposed to stimulate TSH, which is your thyroid stimulating hormone, to release more thyroid. But what we're seeing is we're not getting that normal feedback loop.
Mm,
And when we talk to the patients, they're not having any symptoms of hypothyroidism. Their hair isn't thinning. They're not having swelling. They're not fatigued. They don't have constipation. So it's always, in my opinion, it's better to treat the patient as the whole and how they're clinically doing than chase a number. And if we got rid of their diabetes, we brought down their blood pressure, improved their cholesterol, and they feel great and their T3 is a little low, I'm not going to
gotcha.
treat that. So,
Gotcha.
yeah,
Gotcha.
we are seeing it. And the theory is that once we correct underlying metabolic dysfunction, there's more sensitivity at the level of the cells for these hormones, for your T3 hormone, which is the thyroid hormone again, kind of like with insulin sensitivity and insulin resistance. Once we decrease these high insulin levels, your cells are more insulin sensitive and it can do its job without needing high amounts. And the same theory is thought to be applicable to thyroid hormone.
Interesting. So they can uptake thyroid easier without having as much in the system to do that. So maybe your numbers of what's normal are maybe based on a different population.
Yeah, exact. And this is just a general for all lab tests. They're based on like the average of the general population. And we are in a country where 88% of our population is metabolically unhealthy.
Right.
And that can skew the numbers. And maybe if you're metabolically healthy and fit, your numbers might look off on a normal lab value based on standard averages, but that doesn't mean it's not optimal. Our normal levels are probably not optimal today.
Mm, gotcha. Oh yeah, yeah. Let's think about what blood sugar. I think the what's considered normal or optimal for normal for blood sugar levels has gone up over the last several decades.
Yeah. And testosterone has gone down. A
Right.
lot of I mean, instead of thinking, okay, maybe something's causing these variations, we adjust our numbers to reflect the population.
Yeah, it's like adjusting the size of clothes for the population. It's like the medium, a small 50 years ago is not the same as a small today.
Exactly.
Yeah.
Yes, yes,
So
exactly.
we just range. We have a different level of normal. Excuse me. That's a little scary when you're talking about hormone levels, though.
Yeah. Yeah. It
I mean, it just
absolutely
seems like
is.
that's not something you necessarily want to like change
Shift.
the
No.
goalpost on. I mean, that's like I understood the same about insulin levels. Insulin levels seems to be higher now than they were, say, in
Yeah.
1970s in on average.
So the lab that we use, and
Mhm.
it's the same LabCorp, Quest, Alta. When I test a patient's insulin level, which is a $12.95 test through Alta Labs, not an expensive test.
Right.
When we get the test back, it shows a normal value of less than 19. Ideal is less than 5. Like that is, I mean, once it's at 19, you have some insulin resistance going on. It's crazy to me that that could even be contemplated as a normal range, but that's reflective of the population average.
Wow. Wow.
Yeah.
And reflective of the amount of diabetes I mean, what were we at? 50, 30, really, if you look in real numbers, 13 to 15% of the population is probably not necessarily
Yeah.
diagnosed, but is probably diabetic. And then
Yeah.
from what I understand, India and Asia, even, it's actually much higher. It's almost double that. And,
Mhm.
and yet, so not to get, not to throw in a political bit. I don't mean this by political in any sense, But when we saw such an uptick in COVID correlation with metabolic health. So we saw the big comorbidities with
Mhm.
COVID hospitalizations and COVID deaths. We saw hypertension and obesity as being the top, other than age, okay, which is
Yeah.
not preventable. It's aimed for.
Right.
We all want to get older, right?
Yeah.
But as far as comorbidities, we're talking about hypertension and obesity. So affecting immune function, I would assume, is affecting people's ability to handle
Yeah.
a virus.
Yeah, exactly. It's like we talked about before, everything is connected, and obesity is a inflammatory state, and type 2 diabetes is creating a lot of inflammation from the glycemic variability and other factors. And with that goes hypertension, and it all factors in. If you are not metabolically healthy, you're going to have a much higher or harder time fighting off the coronavirus and any other virus
Mm,
you cross. And you'll see in hospitals, diabetics have more surgical and higher rates of surgical infections, more complications with pneumonia and other diseases that people come across in day-to-day life. And you are really putting yourself at risk from an infectious standpoint if you're metabolically dysfunctional.
gotcha. Wow. Awesome. Well, I mean, this is a wealth of information. I love what you guys are doing out there. It's brave in the
Thank you.
medical industry, and not everybody realizes what I mean by that. But it's brave to take it to do what you've done, was open a practice for prevention, because you guys are not reimbursed by insurance. This is
Cor-
cash business, correct?
Correct. We are a membership-based model, so
Okay.
we have a monthly fee set up, and then you have unlimited access to us. But we don't bill insurance. We're not paid by insurance. This
Yeah.
is all out of pocket.
Yeah, it's a concierge model, so to speak, is what
Yes.
it's called. So
Yes.
concierge medicine. That's fantastic, and yet at the same time, it's unbelievable how many people don't realize the value that. I mean, they think, oh, my insurance doesn't take it. Oh, I can't do it. Well, if they're setting themselves up for the cost of disease, the cost of sickness, and the cost of just being treated for their sickness as opposed to preventing it. I mean,
Right. Right.
besides wear and
Yeah.
tear, even if it was equal, what would you rather be? Sick and
Ye-
treated, or
Yeah.
well and no need of the treatments and
Right.
the medications? Um,
And we do try to educate our patients. You know, we do try to make it temporary. Like our medical weight loss program, 16 weeks, and it's our hope by at the end of those 16 weeks, you're good to go on your own, and
mm,
that'll save you a lot of money in the long run. If you're not diabetic and you don't need our help anymore, you'll be
right.
doing pretty
That's
good.
awesome. So you teach them to run on their own and manage their own
Yeah,
health.
yeah, exactly.
Brilliant. Brilliant. So how can people, no, wait a minute. I can't leave this out. I mean, I know.
Okay.
So you guys started a podcast to help educate people as well, I think.
Yeah, so my partner at our clinic, Brian Lenskis, started the Low Carb MD podcast a couple years ago with his co-host Tro, who's out in New York, um, and that's really taken off. They had been seeing some clinical improvement with their patients with low carb diets, and decided they wanted to do this podcast to raise awareness and make other physicians and people aware that there's options out there for them. And since I joined Brian, I've taken over as a guest co-host on multiple occasions for the podcast, and have some more lined up. So it's really fun. It's fun getting
Cool.
to talk to the guest and hearing their stories, and hopefully provide some good information for people.
Absolutely. So that's Low Carb MD podcast. All right.
Yes.
And your website is Low Carb MD San Diego. Is that
Yep.
that's correct?
Yep.
Okay. So
That's correct.
I'll be sure to include that in the show notes. And I know you are, as I found you, doctoring keto on Instagram, where
That is right. Yep.
that's your personal,
Yeah, yeah, that's and I do mostly nutrition
mhm.
and health post. I don't put too much of my personal stuff, but that's my personal account. Yes.
Right. That's what I mean. It's not from the Low Carb MD business,
Correct.
uh,
Yes, yeah, that is
IG.
correct.
It's what you've been putting out for since before you were even connected with Low Carb MD San Diego. That's how I found you.
That's
You're putting
right.
out great
Yep.
information on nutrition, weight loss, controlling everything we've been talking about for over a year now. So look for her at Doctoring Keto on Instagram. Thank you so much, Kristin. I'm
Oh,
really
this was
excited
fun.
about everybody hearing. It's a fun thing. That's why I started doing it. I really love it. Getting people's stories and then getting this information out from especially from medical practitioners like yourself, physicians who have seen, they've realized, okay, the current model is not working, where people are actually getting sicker, and you dug in and figured out what worked. And part of it was from your own experience, figuring out what worked for you.
Mhm.
And that's oftentimes where it comes from, a transformation story or journey of your own. And you realize, oh my gosh, everybody needs to experience this. Everyone needs to know what I've just figured out. And you've stepped out and you've done something about it, which is amazing.
Thank you. Thank you.
No,
Hopefully it helps
we
some
need
people.
more. We need more. We need more of you.
Yes. Oh, thank you. Well, hopefully what we're doing with these podcasts and things help inspire other practitioners to take that leap of faith.
Absolutely. Well, I look forward to seeing what you guys continue to do, and I hope we'll ask you back on down the road, and we'll hear some more of your success stories. But thank you so much for coming on. I really appreciate it.
Oh, thank you. I had a great time.